In clinical practice, we talk a lot about wanting to have comprehensive biomarker testing for all patients with non-small cell lung cancer. And this is because in lung cancer, our treatment is so personalized and they weigh upon many elements of treatment decision making. In the systemic or metastatic setting, certainly challenges exist related to adequacy of tissue for testing, potentially delays in availability of tissue to run the test, or simply the long timeline, even today, to full genomic profiling results in patients who perhaps are sick or have rapidly progressive disease and really need to rapidly initiate some form of systemic therapy. These challenges are only heightened as we now think about the advances in more complex perioperative therapy that we're offering patients, where now genomic testing doesn't just impact treatment decisions in the metastatic setting, but it also is impacting decisions in that perioperative setting where curative intent definitive therapy may be awaiting the results of those tests. There's a call to action as well to understand how can we triage which testing is absolutely essential prior to initiating that therapy, so things like PD-L1, EGFR, and ALK, what testing can wait and guide post-operative therapy, and how can we improve our healthcare systems processes to get those results to patients and to their physicians as rapidly as possible. This is an area of evolving research when we think about who needs neoadjuvant treatment perioperatively, who needs perioperative chemoimmunotherapy, and who need adjuvant treatment. And our current clinical trial designs in some ways have all demonstrated benefit to the addition of immunotherapy in some form for most of these patients in one of these settings. The question is what strategy is superior to the others. We don't quite yet have randomized comparisons to give us the exact prospective data to answer this question. In my own practice, I do think that the neoadjuvant data has been very compelling. So I think for us, if we think a patient's going to need some form of perioperative treatment, if we can catch the patient in time, we like to offer a regimen that includes a neoadjuvant component. I think there may be some benefit from a disease-modifying perspective to add IO when there's still tumor in situ. You get the potential advantages of downstaging a patient and reducing the complexity or extent of resection needed, and you get that pathologic response data, which I think is very helpful when thinking about potentially guiding the need or lack of need for subsequent adjuvant therapy, and gives your patient some prognostic information as to what to expect regarding disease recurrence risk. And I hope in the future it's also going to allow us to do novel trial designs that can utilize this regimen to try to intensify or de-intensify patient therapy based on that data. And that's where the field is going in lung cancer. I think it's going to allow us to move things forward much more rapidly.